Hello, everyone, and welcome to this Directions in Oncology Pharmacy Peer Exchange. Today, Emory Healthcare and the Winship Cancer Institute pharmacists will be discussing best practices in oncology pharmacy and specialty pharmacy oversight. I'm Ryan Humschild, Director of Pharmacy at Emory Healthcare and the Winship Cancer Institute. Joining me today in this virtual discussion are my esteemed colleagues. We'll start with Alyssa Billmeyer, our Emory Specialty Pharmacy Manager, Amber Draper, our Gastroenterology Oncology Specialist and Oncology Clinical Coordinator, and Kelly Vala, our Lymphoma Clinical Pharmacy Specialist. Today, we're going to discuss topics pertaining to the management of oncology patients by pharmacists within an NCI-designated comprehensive cancer center, including how treatment recommendations are provided, patient counseling and oversight, and the filling of medications within an integrated health system-owned specialty pharmacy. Let's get started on our first topic. Can each of you provide an overview of your role in patient care within the oncology area? If we can start off with Amber.
Yes, I work within the GI Oncology Clinic, as mentioned earlier. At Emory, the pharmacists in the clinics are involved with direct patient interaction. Some of our key responsibilities are patient education, helping to navigate the procurement of specialty drugs such as oral chemotherapy, monitoring our patients for compliance and side effects related to their treatments, and also participating in the developing patient care plans and supportive care recommendations for their various treatments. We also have the opportunity to participate in pharmacy-driven research within our clinics.
Excellent. Kelly, can you describe your role?
Absolutely. Mine is very, very similar to Amber's. As the lymphoma clinical pharmacy specialist, I work alongside our physicians, our APPs, and our nursing team, as well as pharmacists in both the infusion center and the specialty pharmacy to help facilitate that evidence-based pharmaceutical care. This includes, again, treatment decisions and treatment planning with the providers and patients, answering many drug information questions, and providing that education, monitoring, and follow-up, as Amber mentioned. We interface with various team members throughout all of the elements of care at the clinic, the inpatient setting, the infusion center, and the specialty pharmacy to ensure that medication-related treatment plans are implemented.
It's pretty apparent that there's a pretty good integration of oncology pharmacy and practice here at Emory. It's really unique to hear kind of all the different areas that you all are involved. Going from there, let's transition to Alyssa Billmeyer. I know you take more of a leadership role, but you're also kind of integral in the process of overseeing and involved with the oncology medications. Alyssa, can you tell us a little about your role and how it interfaces with our oncology
Sure,
care
Ryan.
model?
So my title here at Emory is Specialty Pharmacy Manager. So my primary roles and responsibilities are to oversee the operations of the specialty pharmacy. So the operations of what happens once that specialty prescription is prescribed. I oversee a team of individuals who work on the prior authorizations. They're advanced level technicians. They work on the clinic's behalf to complete those prior authorizations through avid communications with our clinical specialists like Amber and Kelly. We also have a team of individuals of medication assistants and people who will try to get that copay, that high cost copay of these specialty medications down. Here at Emory, 80% of our patients have a copay of less than $10, and it's because of that great work that team can do through working with copay assistance cards, with the drug manufacturer, free drug programs, foundations, and other services available to that our teams find. And definitely not least, I oversee the team of individuals who do the physical dispensing of the prescriptions. We like to call them the air traffic controllers, and they're the individuals who are taking that 360-foot view of the patient and making sure that everything is being coordinated appropriately for that. So if they realize maybe a patient has an adverse drug reaction or something like that, they'll be working with the clinical specialist in the clinic to escalate that information so they can follow up on it. If they're realizing that a prescription's kind of moving slowly through a process, they'll work with the right individuals to kind of nudge them along the way to see what kind of barriers they're running into. And they ship the prescriptions to the patient overnight or get them to the patient to be able to pick up and making sure that it's delivered to them in an appropriate manner so that they can take that medication and start it.
It's great to see that strong collaboration between kind of the operational the operations and also the clinical specialists that are operating in the clinic. And I think that makes such a difference where that's not always such a close working relationship. So it's great to hear kind of the work you're doing and also on financial toxicity. And maybe we can hit on that later in the discussion. We focus specifically on the strong role the specialty pharmacy plays within the actual dispensing of products. I think that's so important. So kind of shifting now, let's move to some of the clinical involvement as our pharmacists kind of mentioned in their role. And maybe Kelly and Amber, maybe Kelly, you can start this question off, but how are you involved in therapeutic recommendations, and how does that involvement interface with other people in clinic, such as the providers and nursing team?
Sure, thanks, Ryan. There are multiple ways in which the clinical specialists, including myself, are involved in making recommendations. I think one way is really through multidisciplinary meetings, such as tumor boards, where we review challenging patient cases, and we'll arrive at potential therapeutic options with considerations from various members of multidisciplinary teams, including the physicians, radiation oncology, the pharmacist, et cetera, to come up with a really good plan. And in that meeting, specifically facets and implications for specific treatments will come up so that we can arrive at that best option. Each clinic team for me also meets every week to discuss our patients that are being seen that week, or maybe we're seen the week before, need a specific follow-up, so that we can talk through any hiccups in the treatment plan or any upcoming treatment plans to do so proactively. I also answer many questions that come from the team on clinic days, off clinic days, about specific patients and my thoughts on different treatment plans. And I'm able to chime in and speak up about any necessary lab monitoring or tests that need to be done before we start a therapy, so that we can ensure the smooth transition to initiation of therapy, including medications that are going to be prescribed through the specialty pharmacy. So we give ourselves enough lead time to ensure that prior authorizations are done, or medication assistance, as Alyssa mentioned, is able to be put into place so that we can get the patients their drugs quickly if we are going to be starting and the patient needs a new treatment soon. Amber had also mentioned the role of pharmacy-based research. I think in general, we will also implement different practice changes based on research that the pharmacists from our clinical specialist team are able to participate in, and make good overall treatment decisions for patients based on evidence that we generate through our own research.
It sounds like you're kind of a key decision maker when it comes to therapy selection. Obviously, therapy is made through a shared decision, probably with the patient, the provider, and the team. And it sounds like you also have a key point of decision there of helping recommend the best therapy. Kelly, when you have some patients presenting in further line, what's your involvement like when maybe you're talking fourth or fifth line therapy for some of your hematology patients?
Yeah, I think that's a great question. I think reviewing with the patients, first doing a review of their chart, kind of understanding their treatment history, even potentially talking to the patient about their prior treatments, maybe why they did or didn't work well. Is it an intolerance issue, and what, could we use instead that may not lead them to those same issues that they had from a tolerability standpoint. If it's an efficacy question, that's a little bit harder, although we can, scour the literature to ensure that we're talking through sequencing of treatments appropriately, looking through and making sure that we would be avoiding any unnecessary drug-drug interactions, and continuing that high touch with the patients and really following up with them, especially if intolerance to prior treatments was an issue, to ensure that supportive care is not only started from the beginning, but any interventions that need to be made, or recommendations to the team that need to be made, can be done so through that means as well.
Excellent. Amber, how about you? I know you work specifically kind of in a leadership role over the oncology specialist, but you also practice in the GI clinic. What's your involvement in therapeutic recommendations and interfacing with the team?
Very similar to what Kelly said. I think, one of the things that's key to our success is our presence in the clinic. And really being there to have those direct patient interactions and being so accessible to all members of our team, the providers, the APPs, the nurses. As Kelly said, what GI does, we actually run through our patient list every morning, and that does enable us to kind of touch on those patients who may need to receive more supportive care, more closer monitoring, gives us the opportunity to kind of talk through their treatment plans. Additionally, myself in GI, I have a task of kind of maintaining our GI pathway. So that's our treatment pathway. So we actually meet quarterly, and I am responsible for kind of organizing that meeting where we kind of look at the data as a group and make recommendations onto what we think should go on our pathway and what we should be recommending for all of our GI patients. And that is shared Emory-wide. So that's just one additional thing that I do within the GI clinic, kind of helping to guide our treatments for our patients.
And Amber, how does your role as a clinical specialist and kind of elbow to elbow, let's say with the providers and the decision makers, how does it change whether a patient's getting treated with an IV therapy or kind of a home injectable or oral therapy? Does your role change? Is there any different interaction with the patient or the team, or is it consistent?
I would say it's pretty consistent for GI, only because when it comes to pharmacy, they kind of see me as the medication expert, whether it's an IV or an oral therapy. The only way it does change is that when it does come to the oral therapies, we have our specialty program, which I know we'll talk about more in a moment, where we kind of can help navigate the approval of those agents. So I'm more closely in tune as to what's going on with the approval of the oral therapies versus the IV therapies, able to provide more updates to the providers, kind of know more often of like what is going on with the insurance side of things, and if there's going to be any delays in care. I would probably say that's probably the biggest difference between, the role with IV versus oral in that situation.
Kelly, anything you want to add there?
No, I think Amber covered it quite well. It's very similar, IV versus oral. And in fact, at least in hematology, and Amber can probably speak to this on the solid tumor side from GI as well, many of our therapies are combination IV and oral. So we're interfacing with the patient about both types of treatment at the same time.
And Alyssa, I know within specialty pharmacy, right, usually through the pharmacy benefit, but now with white bagging, some injectables getting pushed to the outpatient phase of care outside of just infusion centers, how is your role in your Emory specialty pharmacy stayed adaptable to that as, patients' journeys start to trend differently, inside the infusion center, but then also sometimes going to the home as a site of care?
Yeah, great question. We've done a lot over the past year and a half or so to help with those unique scenarios with patients. The first scenario that I can think of that we've done to help adapt is actually a Meds to Bay program, where we actually work with delivering medications directly to the patient's infusion chair to help prevent them from traveling all around our busy hospital and trying to find our pharmacy. So that's just a unique scenario that I can think of with that. We also have had several patients who are getting denials through their insurance companies from a site of care perspective through their medical benefit, and working with our infusion teams to see if we can provide that medication from our specialty pharmacy from a clear bagging perspective. We've gone through a few of those examples as well. So making sure that despite challenges with PBMs and insurance companies, that we're doing the best thing for the patient to get them their medication, no matter what those feats look like.
Yeah, I really like that comment, because as an integrated delivery network, an NCI designated comprehensive cancer center, the only one in our state, it's so important that we watch each of those handoffs, and whether the medication's being given within a hospital-based infusion center or home, that we have really good oversight with the team, right, and good communication. I really like that integration. And the Meds to Bays is a program I'm a big fan of, because I think it creates that transition of care not only from inpatient to home, but infusion bay to home, which is great, especially considering COVID-19 right now and the pandemic, and us trying to minimize unnecessary stops for a patient after they've received immunomodulating therapy. So, really great discussion. I'd like to transition now more towards the patient education piece. And maybe, Amber, you can start us off with this discussion, but how do you get involved with patient education within your clinic? And I know you talked about this a little bit earlier, but your involvement of educating patients from IV and oral therapies, and how do you start start to educate them? I know it's a lot to take in for our patients when they're newly diagnosed or if they've been referred in. So how do you approach that from a pharmacy practitioner perspective?
Yeah, so within the GI clinic, I've been very fortunate that from day one, I've always been very integrated in the patient's care. That's just part of the culture at Emory. But, it is chemotherapy. So educating a patient about chemotherapy can be very complex. So the way I approach it is every new patient or any patient who's changing their chemo plan, I'm brought in at the end of their visit to kind of summarize what the provider has said, kind of bring it home, so to speak, for the patient. When doing that, I actually have, and so do many of the other clinics at Emory, I have regimen-specific education sheets. So if it's an IV therapy and oral therapy, it kind of walks the patient through what to expect on the day of treatment, walks through major toxicity, major side effects. If it's oral, it goes into how they take their medication, administration, drug interactions, provides a calendar with their treatment so that they can kind of know what time of day they should be taking their drugs. And so all this is given to them during the education. And, unfortunately, we are getting busier and busier. So not all educations can occur in person. And so if I am with another patient or if there's multiple providers that day and I just can't see everyone at once, our teams do message me and I actually follow up with those patients through a phone call within 48 to 72 hours after their visit, just to kind of provide them with that education via phone. So even though in person is always preferred, just the nature of cancer and there's more patients getting cancer, we often have to turn to telephones to provide that service. And then for our oral chemotherapy patients, as we'll talk about more, I know when they're receiving their drugs. So when I know that they've received it, I call them also just to make sure, hey, you remember what we talked about, know how to take the medication, just to follow up and make sure they're comfortable. Because oral chemotherapy, while they are doing it at home, it is still chemotherapy. And so we want to make sure that they're comfortable administering those medications at home.
Oh yeah, those are great comments. And I like that you're so involved in the education. I know here at Emory, you educate patients in clinic, and then also cycle one, day one in the infusion center, our infusion pharmacists are involved in chairside counseling, which I think is important. And also, if I'm a patient and I get to know you in clinic and you've been one of the ones that's helped select my therapy, it's always great to have you be the one to educate me because you know my unique situation as a patient. Kelly, I know you're involved more in the hematology side, and I know you're involved in patient education. Anything different or additional that you want to expand upon as it comes to that patient education journey?
No, I think more just hitting the point home that how paramount it is to ensure that the patient is not only verbally educated, whether that be face-to-face or through telephone or telemedicine. I think we've all learned a lot through COVID-19 and the expansion of, potentially telemedicine services is very intriguing. But also providing written information because the patients are getting a wealth of information from their physician, potentially from the nurse, and from us all at the same time. So really ensuring that they understand what we've talked about. I think, Amber's point is well taken. And I do similar things, especially with the specialty pharmacy, granted, we follow up with the patient within 2 weeks of starting therapy anyways, but, making sure that they really understand how to take the medications and how to do so safely at home to avoid specific drug-drug or drug-food interactions, what time of day is best to take it. I think these are things that patients may not think too much about when they're thinking about starting a new treatment. So they may not know to ask those questions, and us following up with them and making sure they're taking the medication appropriately so it can be as effective as possible is really key to the success of their longevity of their treatment, and making sure that they're going to be compliant or adherent with the treatment as we move forward, since it's really their responsibility at home to continue taking that oral medication as prescribed.
Yeah, Ryan, I just like to add really fast is that one of the really fun things to see on the operations side is when we're making those monthly phone calls to patients. Patients don't just know their doctor's name, they know their pharmacist's names here at Emory. So they'll say, yeah, I remember Kelly telling me about that, or Amber told me to do this. Is that correct? Just wanted to reiterate that. And so pharmacists just don't have doctors, they have pharmacists at Emory, which is really awesome.
I love that response, Alyssa. You really summarized it well. And that oversight is huge. And you're right, a lot of our patients know their clinical pharmacy specialists, they know their infusion pharmacists, they reach out to you all, right? As they see you as another provider that's part of their care team. And that's really exciting. I want to transition. We talked about education, but also there's a huge piece about side effect management. And, with specific therapies, some can create hyperglycemia, some can create specific side effects you want to look out for in terms of nausea, vomiting. I actually want to start with Alyssa real quick. In a URAC accredited specialty pharmacy, it's so important that we're monitoring patients at the right time periods and that we're also looking for certain side effects. I know a lot of people utilize case management systems. That's a required kind of best practice within the specialty pharmacy landscape. How do you work on developing those modules, getting the content, ultimately making sure before a patient's dispensed their oral chemotherapy or home injectable that all of those, side effects are being monitored and looked at?
Yeah. Well, we utilize a case management system called Theragy, and Theragy is, we've kind of built it out from a homegrown perspective, not using their pre-built modules. And we built that out with an integrated model. So having input from our frontline staff from the clinical side, as well as the operational side. And we kind of have two different branches each patient has. So they have their operational branch that works through refill management and making sure that operationally you're getting the patient the drug when they need it, but then also that clinical side. We make sure that we never dispense a medication to a patient unless if they've got that first initial education, and our staff is definitely trained to make sure they're looking for that ahead of time. But even before that, we're making sure that we're never dispensing, or even after that, we're making sure we're never dispensing a prescription unless if our pharmacist has given the approval. So each month, a pharmacist is, before they're giving that approval, they're looking through the chart, making sure that patients' labs look appropriate, making sure that they haven't called into the doctor's office with side effects, even reviewing the documentation within our Theragy charts to make sure like everything looks like it is going appropriately, and then giving that ready to ship from there, or that ready to dispense from there. Our team we have different branches. We have our clinical oncology side, and then also our non-oncology sides as well. But we've just actually recently gone through an entire revamp of what our oncology workflows look like from the clinical perspective. And again, that was a multidisciplinary team that chose how to follow up with patients based off of the patient risk and what they look like from, are they a high risk patient or are they a low risk patient, but also the medication risk. So stratifying medication based off of their clinical assessment. And we've been going live with that for about 6 months now, and it's been really great. And really good feedback from both patients who, some of them maybe too much follow-up. And then also from our clinical specialists who feel that they've actually been making more of an impact.
Amber, Kelly, anything else you want to add around side effect management as it pertains to your
patients? The only thing I would add is that, like Alyssa kind of touched on with the oral chemotherapy, part of our process is calling patients after they've started treatment within a specified time frame. And that really enables us to intervene early for any side effects. So before a patient, it gets too out of hand, they go to the ER, or, instead of the patient waiting until they come back to see their provider again, we can kind of intervene and, possibly keep that patient on treatment longer by helping them manage their side effects early and preventing them from getting too severe. And also, when it comes to IV therapies, we are closely engaged with our nursing colleagues, because I feel like most of the side effect management occurs via the phone. Patients call after they've received their IV treatment, so they send emails. And our nursing colleagues do a great job of kind of looping us in and asking for us to give our recommendations and for our input on how to manage those toxicities. So that was just all I wanted to add.
Yeah.
I would say fairly similar answer here. I think what's great is, as Alyssa said, some patients will call the specialty pharmacy, or when they're talking to the specialty pharmacy staff, they'll mention their own pharmacist from clinic, and it's a really great working relationship that we have with the specialty pharmacy. And that if a patient does ask a clinical question that they feel is out of scope from the specialty pharmacist perspective, I'll often get a phone call. Can I transfer this patient to you, or can you give this patient a call back about this potential side effect that they may be experiencing? And I think that's a great way that we're able to intervene, as well as, the follow-ups that we do. I've been able to, make recommendations for supportive care measures. Not only that, but, request to the clinic team that the patient may need to be followed up sooner if they may sound like they might be progressing or really experiencing a side effect that we may need to be making dose adjustments for.
That side effect management, what I like about it is by being proactive in our side effect management strategies, we can keep patients on therapy longer. There's nothing worse, in my opinion, of seeing someone have rate-limiting toxicities around their therapy and having to progress to another therapy or having to get off altogether, especially when they're having a great response. And so, you all play such an important role. Our pharmacy too plays such an important role as a team of making sure we're able to do that and keep patients on the most ideal therapies longer. And kind of like Amber mentioned, sticking to our pathways as long as possible, I think will provide the best outcome, whether it be progression-free survival, overall survival, or durability of response. Finishing out, I want to talk about this one section here is really when we transition patients between IV and oral medications. I know that comes with close teamwork because, like you said, nursing's involved, pharmacy's involved. Maybe one or two you can mention, what does that process involve and how difficult is that, especially when we're looking at transitioning between different prior authorization teams, as Alyssa kind of mentioned earlier, or potentially between nursing and pharmacy in different phases of care. What are some strategic roles that you play within that process that have aided the patient in having kind of more a streamlined approach where they don't feel the difference, even though there might be a lot of work happening on the healthcare side during that transition?
I think knowing the patient's treatment plan and being as intimately involved and integrated into the team as we are, we're able to simultaneously ensure that the correct oral medication is prescribed along with orders being placed for IV therapy, and that the pre-certification or prior authorization for each is being submitted. And continuing to follow up using our nursing colleagues to help us from the clinic side, from the IV side, to make sure that the IV therapy is going to be able to be given at the time that it needs to be given in regimens that combine both oral and IV, and really serving as that liaison and being responsible to ensure that the prior authorizations or medication assistance and communicating back to adjust any potential treatment delays that may occur because we're waiting on the oral drug. Oftentimes I find that our turnaround times are amazing from our specialty pharmacy. So really, it seems like I don't have to do a whole lot of extra work at all. In that we have great staff on the specialty pharmacy side that ensure that those processes happen, and that really, making sure that our patients are scheduled appropriately for the IV therapy is rate limited by either the pre-certification team and hearing back from the insurance company and or just chair availability in our infusion centers and making sure the patient can get scheduled when we want them to.
Yeah, I just would like to add that for the transition to oral therapies, keeping the prescriptions within our specialty pharmacy really does make things so much easier from a transparency perspective. We're not sitting in the clinic waiting to get faxes from an outside specialty pharmacy saying a prior authorization is needed or that an appeal is needed, which can create, days, if not weeks, of delays in a patient receiving their medication. Because we're able to keep it in-house and, we know exactly what's needed every step of the way. And we're also able to keep the patient engaged with what's going on and the approval status of their medication. So I feel like we are able to decrease a lot of anxiety that many patients have around receiving oral medications compared to their IV therapies.
Amber, you mentioned a lot of good things, and one of the things you specifically hit on is the role and the interaction with the specialty pharmacy and how important it is to our patient care model. How do you interact with the specialty pharmacy patient care continuum? In other words, there's several individuals involved in specialty pharmacy. Alyssa really hit on that at the beginning, from medication access specialists to medication assistance coordinators to the air traffic controllers that are actually working in the specialty pharmacy doing a lot of the dispensing. How involved and how much do you interact with those team members in addition to your clinic duties and kind of therapeutic recommendations?
Yeah, so I think one of the things we've really demonstrated well at Emory is that we don't all have to be in the same physical location to achieve the outcomes that we have. So we have the clinical specialists in our clinics, which are scattered all over Atlanta, and then we have our specialty pharmacy, and we have some people who may work from home, et cetera. And a lot of the key to that success is, using a program, Alyssa mentioned Theragy earlier, to kind of navigate our patients and know when refills are due, know when tasks are due. That's how we kind of communicate with one another throughout the day. So frequently, as part of my day, I will go in and kind of scan to see, are there any updates on a patient's therapy, anything that's needed from me from the specialty pharmacy, or, if they're sending me a message. I think we've also done very great this past year of learning to use different methods of communication, such as Microsoft Teams. So frequently I'm messaging one of the patient care coordinators asking for an update on a PA, or, someone within our department that helps with drug assistance to see, status of an application. So I feel like we just have really great lines of communication with the specialty pharmacy, and I don't really feel like there's any ever problems getting in touch, or getting someone to answer a question that I need answered, even though they're not physically in the same building or location that I'm at.
Partnership is such a key, it's a core value of our department, as you all know. And it's one of the key things that I think creates a really great end experience for the patient. There can be so many handoffs involved, but we're the ones that are communicating so that at the end of the day, they get their medication faster, more accurately, and also kind of in a way that's efficient and effective for them to understand how to take the medication. Kelly, you work in the hematology space. How was your interaction with the specialty pharmacy team? Are you similar to Amber? Do you have a team that's kind of supporting you and your patients to making sure they get their medications on time?
Absolutely. And I think the points that Alyssa had made a little bit earlier regarding how we've developed, our process for follow-up and those types of modules, and being integrated and having everyone really come to the table from the beginning to ensure that we all sort of know how we're going to make this function, and how we do make it a success, and revisiting that and making sure that everyone's opinions and ideas are able to be heard. I think everyone feels very comfortable, and despite us having a very large clinical specialist team, large specialty pharmacy team, it doesn't feel that big, and it feels like we really do know each other, even if we're not in the same physical locations. It's very easy to communicate through Teams and through Theragy to get rapid answers and make sure that patients are going to get their medications as quickly as possible and at an affordable price. So speaking with our patient care coordinators and medication assistants specialists, it's very easy to get in touch with all of them and make sure that we're all coordinating care, and the ball does not ever get dropped, in my opinion.
Yeah, and I just kind of like to add too that the communication goes the other direction as well. So we have many times where we're in the specialty pharmacy catching things that just don't seem right, or that a patient might have a question, and escalating those to the clinical specialist right away to make sure that those are followed up on. A really good example is, we've caught sometimes where, we know that at the pharmacy that every abiraterone needs a prednisone with it, and sometimes that's not prescribed with it, and we're just trying to make sure that the patient gets their prednisone too. So giving, that clinical specialist a quick phone call saying, hey, we don't have a prednisone, can you send that over our way right now? They'll get that done in 5 minutes, versus if it was an outside pharmacy, that could potentially get done days later too. So making sure that patients getting the full care, and if something does accidentally slip, we're following up on that.
Alyssa, I want to build upon something you said, because I agree. I think there's so many benefits of an integrated health system owned specialty pharmacy. And I think it goes far beyond just who's filling it, but it's this integration you're seeing of the team members, how it's connected all the way to clinic, and provides really a unique environment for a patient to really succeed well. And I know in the health system environment, a lot of hospitals and health systems that have large integrated specialty pharmacies are starting to publish more of the benefits of their programs. And we're explaining that not only to employer groups, the patients are feeling it, but I think our pharmaceutical manufacturer partners are also seeing this when they're considering limited distribution considerations. Alyssa, if you could share with us, what do you think are some of the key unique differences between a health system specialty pharmacy compared to your kind of traditional external specialty pharmacy, both from the patient perspective, but also kind of on the whole care continuum?
Yeah. When I think about health system specialty pharmacy, and especially the way that we operate here at Emory, I really truthfully think that we look through our true north, and our true north is the patient. It's not finances. It's not making sure that it's not making sure that anything but like at the end of the day, our patient is getting the best care possible. And we've got a team here, and Ryan, under your direction, we've built this team of building team members who truly believe in that true north. And so here at our specialty pharmacy, we'll do anything to make sure that we're getting care for that patient. Just the other day, Kelly was talking about a patient, called me about a patient on a Friday evening, I think at 4:00 p.m. and we close at 5. And she's like, hey, someone needs a medication and they live in North Georgia, hours away, and we can't get that to them. She needs it by tomorrow at the latest. Is there anything that we can do? And we had a team of people scrambling, trying to figure out how to get that to the patient. And I don't think every pharmacy would do something like that. And so at the end of the day, we're going to go above and beyond for those individual patients, when I just don't think every other pharmacy will do that, because our true north is the patient. I think our integrated communication is really helpful. When I share about our specialty pharmacy, I don't just talk about our pharmacy team members working in the pharmacy. I talk about our clinical specialists. I talk about our providers. I talk about our nurses. I talk about our medication access specialists and our medication assistance team. And we really do have that full team approach. And we're all in one location, so we can one virtual location, and we can communicate and see what the other hand is doing. And I think that really helps with the patient care and that patient care process, and making sure that we're getting them their medications in a timely manner. We've done studies to show that we can get our medications to patients 4 days faster. We can get we can make sure they have their medications on hand all the time, and that our patients are more adherent. But I think that there's more beyond that we haven't yet studied to show that our patients really do have better outcomes because of that communication and that care. And I do think our patients enjoy our team members too. Whenever I help out in the pharmacy, there's without a doubt that I'm connecting with a patient who doesn't know I'm the manager of the pharmacy, but just gives our pharmacy praises about how much better they like our pharmacy compared to previous pharmacies that they've been with, and how they appreciate our above and beyond approach. And, those are things that you can't necessarily study, but you can feel. And I think that's what makes us different than the outside pharmacies.
I couldn't agree more. And part of it is you connected really the work we're doing, right? That great customer service, but also that integration. Because at the end of the day, we want to improve outcomes. And Alyssa, I know you talked about a publication around us providing those patient improvement, those outcomes, and that actually got published here by Emory and the Winship Cancer Institute. And I really want to start off maybe with Amber, if you can chime in. I think I'm interested in hearing, you have been a part of that, right? And Kelly, you have too, but you also deal with patients that fill it outside specialty pharmacies due to payer restrictions, and also the Emory pharmacy. And what impact do you think that makes on the clinical outcomes for our patients, which I think is one of the most important things that we're working towards improving?
Yeah, I think, definitely there's a difference in the clinical outcomes of our patients that fill within our internal specialty pharmacy versus outside pharmacies. One of the biggest differences is that at Emory, if you use Emory specialty pharmacy, the pharmacists you're engaging with in the clinic and in the specialty pharmacy they're disease state experts. So we are, as Kelly and Alyssa we've all mentioned earlier, we know the patients, we know their past treatments, we know how they tolerated therapies. As more and more treatments become genomic specific, we know patients' genomic profiles. We know if a patient should or should not be receiving a drug based on their mutation status. And because of that, and because we know all that background, I feel like we can offer, we have better outcomes in our patients when they fill internally in our pharmacy, because we are so involved and engaged, not only in, their oral chemotherapy care, but we've been there from the beginning. So, we've been part of their care from the very first time they stepped into Emory. We also, as Alyssa has alluded, we have data that shows our patients are receiving medications more quickly and have better adherence. And I think that adherence is because we do follow them for refills. We know if a patient is having imaging, we know if there's a chance of progression, not just send a refill, for that patient. We know they're going to be coming off therapy. We know whenever I get a message from someone in the specialty pharmacy saying, Mr. So-and-so has 2 full bottles at home. Well, then I know there's a compliance issue, so I'm able to intervene earlier and, loop the provider in on, that we need to watch this patient a little bit more closely. I think all these small things, really lead to very big differences in the clinical outcomes of our cancer patients when they fill at our pharmacy versus when they go to an outside pharmacy.
I would agree with Amber. I can't drive home the point hard enough that it really, you lose a little bit or you create a little bit of a disconnect when you're filling through an outside specialty pharmacy. Unfortunately, occasionally that is the case just due to those payer restrictions. But really, we don't know what's going on there. When we really have a clear, transparent process here. I had today a patient who called in, I know they've spoken to the pharmacy staff, but they still called in to the clinic team and said, I'm running out of medication. Who do I need to talk to, or what do I need to do? Well, I had already provided that ready to ship. Our team had already reached out to the patient multiple times and actually talked to him, and it had been shipped yesterday for delivery today. So it was easy for me to tell the nurse who was taking that triaged phone call, hey, here's the status of that. It was shipped yesterday. Please have the patient call us if they're not receiving this by this afternoon, so we can look into that shipping tracking and making sure that they're getting that medication that they need. Whereas we don't really have a whole lot of control or as close of communication when we're filling through an outside specialty pharmacy.
Yeah, it seems like, the future is getting more involved as health systems and having more accountable to our patients. And I think part of that is, unique payer contracts, right? Where you lean towards more value-based outcomes, you become more reliant, like you said, on that integration and handoff and that adherence. And ultimately, adherence plays such a huge role in patient-owned medications, specifically within oncology. And we want patients to not only have the best results, but we want them to mimic the clinical trial. And it's more difficult to do that when they don't get access to those medications, or they don't have those reminders, and they're not taking the medications as appropriate. And as we look towards the future, one of the things we've led in is kind of this integrated model. And also, as Amber mentioned earlier, kind of pathways of treatment. And I think it's so important that if you have medications on pathway and you start to have really consistent best practice use through disease state working groups, you'll get some of the best outcomes. And that allows you to be successful in value-based contracts. But at the end of the day, if I'm a patient, no matter what facility of Emory's or Winships I go to, I want to make sure I'm getting that best care. And I know that's what we're striving for. And by having that all funneled to the exact specialty pharmacy, that consistent oversight, counseling makes the difference. And so, I want to open this question initially to Alyssa. As we look at the future and the horizon for the management of oncology patients with the Emory Specialty Pharmacy, do you see more of this integration building? Are there any changes that you see in the horizon that either are going to improve patient care or barriers we have to work through as we continue to want to own and be responsible for our oncology patient outcomes?
Yeah, I definitely see a lot of changes that are in our future. I think most of the changes from patient management are probably going to be more on the payer side and how we manage and contract with payers. I think if we can show payers, those outcomes that we've talked about earlier today and the difference that we really make, and prove to them that, we can actually care for their patient as a whole, from, going to their doctor's visits to getting their infusion and providing their infusions on within our health system, and then also caring for their oral and supportive care medications, oral specialty medications and supportive care medications. I think that can really, I think we can show the benefit. And so it's our job as a health system, specialty pharmacy, and as a health system in general to communicate those, improve that worth to those payers. I think that that's the biggest change that I see coming forward. And we're already making moves to kind of prove to them and show them that those are things that we can do, working with our infusion center counterparts who, Ryan, are right under our team. So it's the same team that are managing it from a clinical aspect, working with them to create that integration, like I talked about earlier. And so I think that, like I said, that's the biggest change I can see.
And the future of pharmacy practice, I think, is evolving. And Kelly, I'm kind of curious, a lot of more progressive departments are leveraging collaborative practice agreements with their physician team members. And it allows pharmacists to get more involved in titrating medications, maybe initiating prescriptions for certain supportive care medications to make sure patients are, successful in therapy. How do you see your pharmacy practice continuing to develop alongside the specialty pharmacy as we kind of keep moving forward the future of cancer treatment?
Yeah, I mean, I think in some ways the future is already been happening or is happening now, in that we do have collaborative practice agreements. I think really the progression of pharmacy practice is going to depend on advocacy for pharmacy provider status, so that we can really be making those autonomous and independent based assessments and recommendations. I would say that my providers already, trust that I'm making a recommendation. When I'm running it by them, it's almost a formality in many, many cases, in that they're like, of course you can do that. You didn't really need to ask me. Say, well, I do need to ask you, if that's okay. But, hopefully in the future, we'll be able to make those assessments for dose adjustments, adding medications, very independently, and be able to kind of follow those outcomes, and take some of that work off the plates of our provider colleagues and our physicians and our APPs, and be independently following some of these patients. I know some states have a little bit more progression than others, but hopefully we'll all kind of get there across the board sooner rather than later.
And, I think what you said is key. It's a team-based care and leveraging the unique skill sets of everyone on that team so the patient benefits. And Amber, I'll kind of ask this question to you too, because as the oncology clinical coordinator, you work with our talented clinical specialists like Kelly that are uniquely trained in each disease state. And as you think of the team's development, anything you want to add in terms of future pharmacy practice that you see occurring, or future involvement in kind of taking care of the patient outside of what we touched on already?
Yeah, I think Kelly hit on a lot of the high points. We work under a collaborative practice agreement right now within oncology, but I think there's always opportunity to kind of explore and, if there's opportunities to be seen more as provider status. And like Kelly said, some states are more advanced than others with doing that, but I think we are definitely on the right path at Emory and heading in that direction. And I think just, exploring those opportunities it is always kind of comical that, the providers come to us for dose adjustment recommendations, but we because we're not providers, we can't technically just do that on our own. But I think there's a lot of opportunity to explore those opportunities down the road, and how we can just become more integrated in patient care. I think we have a great model at Emory. We're fortunate that almost all of our oncology clinics have a clinical pharmacy specialist present. I think so much so that sometimes our providers don't realize what our limitations legally are. And so I think, we just have to continue to advocate and really encourage, pharmacists to be seen more as providers. But like I said, I think Emory, we're far ahead of most organizations, and I think eventually we will get there too.
I want to finish out with this last point, because I think the future is exciting, but the future is going to be valued too on the way we're able to impact outcomes. As many of you know, I feel like PBM-owned specialty pharmacies, health system-owned specialty manufacturers are all trying to figure out who should I limit the distribution to, who should be able to fill this medication. And ultimately, we want to do what's best for the patient. And I think if someone can improve outcomes, you're going to reduce that total cost of care. You're going to give them the best chance of having the best outcome of the therapy. And I think that's really going to drive value as opposed to volume or just being owned. Because at the end of the day, when you're able to provide a great outcome at a reduced cost, that's really what's going to add value back to the employer groups and a lot of the self-funded insurance plans that are utilizing a PBM to manage that. And so as we look towards the future, and maybe we can start again with Alyssa and Kelly and Amber to finish this out, is, traditionally a lot of specialty pharmacies used medication possession ratios, and they use time to treatment. And those are operational surrogates that speak to the clinical value. But I think a lot of people are wanting to push forward. And as a lot of medications transition from IV to oral or self-injectable, they're looking at some of that research of patient-reported outcomes, quality of life, some of those hard outcomes that we can show, hey, the people that are managing this medication are improving the end result. And so I don't know, Alyssa, if you have any ideas of what the future of outcomes look like for specialty pharmacy outside of just the operational benchmarks that many currently utilize.
Yeah, I'll take a non-conventional approach to this, and I'll let my clinical team take the clinical approach to this. But a lot about what I've been talking about in today's discussion is, the feeling that a patient gets because of our program. And so I think that, in order to also show our impact, we need to kind of look at the difference that a patient feels between filling at our pharmacy and a specialty pharmacy that is not a health system based specialty pharmacy. I actually have one of my individuals who joined my team as a medication access specialist because she ran into so many problems with her husband's medications in navigating the specialty pharmacy world. And so she told herself, like, I'm a technician. I know people have roles like this, and I'm going to go and make a difference. And so that's why she's joining our team to make sure other people don't experience what she experienced with that outside specialty pharmacy. And so I do think that, payers and manufacturers and even hospitals should look at that whole patient experience. We have teams within our health system that just look at the patient experience. So what does that mean from a specialty pharmacy perspective, and how do health system specialty pharmacies compare to those non-health system specialty pharmacies in that patient experience? So that's what I would look at.
Yeah, I think to add to Alyssa's, more of the conventional approach, I guess, from the clinical side is, I think integrating patient-reported outcomes is coming down the line. I think based on, much of what Alyssa touched on, we can trust that our patients are going to report great outcomes from filling within our own in-house specialty pharmacy versus others, because they do feel like they're getting that comprehensive care from the entire team, and that their team all can communicate so that their care is streamlined and it's clear to everybody what is going on. So there's not any sort of lapse in communication between the dispensing of their medications and the clinic team. I think, looking at potential other ways to prove to payers the benefits of this type of integrated pharmacy model, and not just includes the patient being able to get started on medication, but how long the patient can stay on their medication. And a lot of that really ties into our involvement in making sure that patients are supported well while they're on their oral therapy, that they are compliant or adherent to that therapy to make sure that they're having the best outcomes. So I think more markers of long-term adherence to medications, in addition to making sure that or publishing, researching that patients' adverse effects are being clearly taken care of so that they can stay on therapy. If those are the reasons that many are coming off, that'll be very helpful to show that an integrated model such as this is truly the best bet for our patients.
And Amber, why don't you finish us off with your last thoughts here?
Yeah, I think, just a second and echo what Alyssa and Kelly have said. I think what's going to become most important is, not just getting the patient the pill, but what happens after the patient gets the pill. So ensuring compliance, being proactive in managing those side effects and toxicities early on. And also I really think the key to that is having this integrated model where you have disease state experts who are really advocating on behalf of the patient in the clinic and also in the specialty pharmacy. And I think that's kind of what, to me, the direction that specialty pharmacy within a healthcare system needs to go. Is just to be mindful that having that integrated approach really does lead to, in my opinion, better patient outcomes, not just because the patient gets their medication more quickly, but also because we know that they are staying on it, they're being more compliant, and they're being followed by someone who knows them well, but also who knows their disease well.
I just want to add one more point to it. I think the other thing that we can do from an integrated standpoint is that we are, intimately involved with the whole process and even just social determinants of health. as we move forward. Alyssa and both Amber and I have talked about this and about our medication assistance team, but the fact is that we do know these patients well, and we can work with our social workers as well, and making sure that the whole patient is taken care of. It's a little bit clearer when you're integrated to the team rather than at a non-institution based specialty pharmacy, that you can really get patients the care that they need for their whole care, and making sure that they're able to make it to their clinic visits, make it to where they need to get to, making sure that they're able to physically get the medication. So we ship through FedEx, making sure they have a reliable place to receive that medication or to pick it up at the pharmacy on site. I think those are really additional benefits to having an integrated model overall.
Well, thank you all for your summary of an integrated model. And thank you so much, Kelly, Alyssa, and Amber, for joining us today and sharing your thoughts and perspectives about how progressive we are in our pharmacy oncology practice, how we integrate with the specialty pharmacy, and ultimately provide our patients a better experience, better outcomes as we look to the future, a better overall care model. With that being said, thank you to everyone who joined us for this episode of Directions in Oncology Pharmacy Peer Exchange, Emory Healthcare and the Winship Cancer Institute's best practices in oncology pharmacy and specialty pharmacy oversight. Hopefully you had some key takeaways here on the benefits of the integrated specialty pharmacy model, how you can establish a progressive pharmacy practice that's integrated to provide really great patient care and optimize your ability to get those outcomes that you want to achieve. Thanks, everybody, and we look forward for you joining us on another episode of Peer Exchange in the future.